We now invite the following participants to the stage. Professor Rui Nunes, head of the International Chair in Bioethics, will be the chair of the session. Dr. Otmer Kloiber, Secretary General of the World Medical Association, to moderate the session. We also invite to the stage our three distinguished speakers. Ramin Parsa-Parsi, who will present the introduction to the Declaration of Helsinki. Resneck, who will talk about the current status of the revision process. Dr. Resneck is joining us remotely via Zoom. Florentino Cardoso, who will discuss about the Latin America perspective on the Declaration of Helsinki. Additionally, we ask Dr. Miguel Jorge to comment the session. They will provide an evaluation of the new version of the Declaration of Helsinki. We now hand over to Professor Rui Nunes as chair the session.
Good morning to all of you. I hope that you are enjoying this 16th World Conference on Bioethics, Medical Ethics and Health Law. Now we are going to promote a panel from the World Medical Association, and my warm greetings to Dr. Otmer Kloiber, that will be the moderator of this session, and to the World Medical Association, that is a full partner of this conference. And indeed, without this partnership, this conference is not what it is today, and I hope in the future. We are going to approach the new version of the Declaration of Helsinki, that, as you know, in many countries is the fundamental instrument that regulates human research. And so, of course, it's very, very important that the bioethics and biolaw community have knowledge about this new version and also to make suggestions so that this new version that, as far as I know, will be approved in October by the General Assembly of the World Medical Association can be even better than it is today. So thank you very much for your presence, and now I will hand over to Dr. Otmer Kloiber, and thank you very much again.
Thank you very much, Rui, for inviting us to have this session here with us. It is already a tradition that we have sessions on our policy projects with this conference series, and I'm very happy that now, again, we can have a session on the Declaration of Helsinki. The current version of the Declaration of Helsinki is called the Fortaleza version. That is not because there are nice beaches in Fortaleza, it is because it was decided 2013 and adopted 2013 in Fortaleza. Now, we have a tradition that we revise, and Dr. Resneck will speak a little bit about this process, how that is being taken part and has been unrolled over the past years. But I would like to stress at this moment our gratefulness to our colleagues here in Brazil, not only here at the Council, but also at the Brazilian Medical Association, because you have given us the chance to have many of the discussions here on your continent. And indeed, there is no other country where so many discussions have taken place on the Declaration of Helsinki than Brazil. Now, in order to help you a little bit understand what we are talking about, and I guess some of you are familiar with the Declaration of Helsinki and may even use it in your work, for instance, in Ethics Committee, but for all of you, we have asked Dr. Ramin Parsa-Parsi to give an introduction to the Declaration of Helsinki and a little bit a review of what has happened so far in the last 59, now 60 years of the Declaration. Ramin heads the International Department of the German Medical Association, and not only that, he has previously led the revision of the 2013, the Fortaleza version, so he is best positioned to give you an insight on the development of the Declaration of Helsinki. Ramin, please go.
Thank you, Otmer. Thank you very much, and thank you, Professor Nunes. I would also like to thank the organizers for giving me this opportunity to give you a quick reminder on what the Declaration of Helsinki is, what its history is, the principle, the main principles, and its relevance. And Otmer, I really like the term, the Fortaleza version, because indeed it was in Fortaleza, and this is my conflict of interest, because back then I was actually heavily involved in the revision process, and I'm also currently a member of the work group that revises the Declaration of Helsinki again, and in these capacities I got travel grants from the WMA to attend conferences such as this. But let me start by asking you a question. I would assume all of you know the Declaration of Helsinki, right? Who knows the Declaration of Helsinki? Please raise your hand. Okay, I see many hands, and I want to see the hands here too. You should know that. Okay, I expected that. But now show me again your hands. Who knows it because it's a literary masterpiece, because it's so beautifully written and so nice to read? Okay, I suspected that. There are no hands above, because it's indeed true that the work groups that revised the Declaration of Helsinki, for them it was always important that the language is very concise and clear, and that has always given priority over any beauty of the language or any literary value. Now, the Declaration of Helsinki is indeed considered as a core document of the World Medical Association. It's probably the most known and widely used WMA document worldwide, and it's indeed regarded as a cornerstone document of research ethics. And the DoH addresses the same core issues that are at the very heart of why the WMA was initially established. The WMA was established in 1947 in the aftermath of the Second World War and some of the most horrific ethical failures of physicians that occurred during that time. And it was set up to reaffirm the norms of medical research and practice that must apply to all doctors, and to prevent breaches of ethical conduct among physicians in the future, but most importantly, to re-establish trust among patients for physicians. Now, there are 3 documents that outline the basic ethical principles for physicians in both the clinical and the research settings. First of all, there's the Declaration of Geneva, and we have referred to that a couple of times during this meeting. It's the Physician Pledge, adopted in 1948, and based on that, it's the International Code of Medical Ethics, which was approved by the WMA General Assembly just a year later. It's the foundation of ethical principles defining the professional duties of physicians. And then, of course, for the research, there is the Declaration of Helsinki, which was actually approved a couple of years later in 1964 and most recently revised in 2013. And as already mentioned, it's currently undergoing another revision process. Now, the DoH addresses a challenge and a conflict that may arise between two key aspects of medical research. On the one hand, the fundamental obligation of physicians to do no harm. And then on the other side, the essential need to ensure the efficacy and safety of medical interventions by testing them on human research subjects. And the DoH sets the tone right in the beginning. The primary obligation of the physician is to the patient. And it continues by referring to the Declaration of Geneva. The health and well-being of my patient will be my first consideration. And it goes on, it is the duty of the physician to promote and safeguard the health, well-being, and rights of patients, including those who are involved in medical research. And in another paragraph, while the primary purpose of medical research is to generate new knowledge, this goal can never take precedence over the rights and interests of individual research subjects. Now, a little disclaimer here, this is the current wording of the Declaration of Helsinki, the Fortaleza version, right? So, as we already mentioned, the DoH is undergoing revision right now, and some of this language might be fine-tuned, and there will be a new version from 2013 now. Now, what are, from October on? Now, what are the key principles? Respect for patient autonomy, the careful assessment of risks, burdens, and benefits, scientific requirements and the requirement for research protocols, provisions for research registration and publication and the dissemination of results, and the protection of the privacy of research participants and the confidentiality of their personal information. And then in 1975, the need for approval by ethics committees was introduced, which contributed to the development of research ethics committees in many countries. And the rules were even tightened in 2013 to state that these committees must be transparent and their members duly qualified. Then there are a couple of paragraphs dealing with the requirements for informed consent and procedures for individuals who are incapable of giving informed consent. And these paragraphs have been reworded and fine-tuned over the years and the different revisions in the past. And then there are the requirements to seek consent for the collection, storage, and reuse of identifiable human material or data. And that paragraph was extended in 2013 to cover biobanks. Now, this, of course, doesn't completely and comprehensively cover all aspects and challenges that are coming with biobanks. And the WMA has a separate document on this matter, the Declaration of Taipei. And the current work group also discussed how this wording in the current version of the DoH could probably be fine-tuned to refer to the DOT or make it a bit more comprehensive. And I'm sure that Dr. Jack Resneck will elaborate further on that. Now, there are a couple of paragraphs that have always been a little bit more controversial, that have been intensely discussed over the years. There is, for example, the paragraph on the specific protection of vulnerable groups, which was expanded in 2013. It now includes a stringent set of conditions. Medical research with a vulnerable group is only justified, and then there are three conditions. The researcher is responsive to the health needs or priorities of this group. The research cannot be carried out in a non-vulnerable group, and this group should stand to benefit from the knowledge, practices, or interventions that result from this research. And this paragraph has been heavily discussed during the past revisions, but also during the current revision, and the WMA put a lot of effort into this to make it as optimal as possible to cover all the different perspectives from around the world, and we had even dedicated conferences this year to deal with this subject, and again, I'm sure Jack will elaborate on that. There's a paragraph on compensation, which has also been discussed controversially in the past. A paragraph was added in 2013 stipulating that compensation must be provided to research participants who are harmed as a result of participating in a study. Now there's the subject of post-trial provisions. And of course this subject in this paragraph has been controversial ever since it was introduced in 2000. And it's on post-trial access to the best proven prophylactic, diagnostic, and therapeutic methods identified by the study. This paragraph was introduced to ensure access to the prophylactic, diagnostic, and therapeutic methods that were identified in the study. This came in 2000, but then in 2004, the WMA added a note of clarification and extended the access to other appropriate care. 4 years later, in 2008, the note of clarification was removed, and the wording was taken on in the main document, but another word was added to the access provisions. Now, access to intervention identified as beneficial in this study or to other appropriate care or benefits was added. So it became a little bit more vague, the wording. But then in 2013, the last version, the current version, this paragraph now clearly states that participants are fundamentally entitled to access interventions identified as beneficial in the trial. So there was a step back again, and the paragraph was tightened a lot. And it was also added that this information must also be disclosed to participants during the informed consent process. And then there is the placebo paragraph. And you can probably imagine this has always been a very controversial paragraph. We had a couple of conferences on this topic in the past. I distinctly remember some very interesting conferences we had here in Brazil, and I'm sure our colleagues here remember that too. Very good conferences on a very high level. And the 1996 and 2000 versions of the DoH actually introduced a wording saying that placebo may be used as a comparator when no proven intervention exists. So this is how it started in the DoH with this wording. And then in 2002, again, a note of clarification was added by the WMA saying that placebo-controlled trial may be ethically acceptable even if proven therapy is available if two conditions are met, namely if there are compelling and scientifically sound methodological reasons or if patients would not be subject to any risk of serious or irreversible harm. So back then, these two conditions were linked with an or. A few years later, in 2008, this note of clarification was removed, and this wording was then changed and put into the main document, and the two conditions were linked with an and instead of an or, which of course added additional protection for study participants. Now, placebo would be acceptable when proven interventions does exist only if there are compelling and scientifically sound methodological reasons and if patients would not be subject to any risk of serious or irreversible harm. And then this sentence was also added, extreme care must be taken to avoid the abuse of this option. And as you can imagine, this paragraph has also been discussed during the current version, and Dr. Resneck will surely say a few words on that. Now, in the 2013 version, the 2008 wording was almost identically taken on again, but it was extended to the use of any intervention less effective than the best proven one. I'm not going to read the entire paragraph now because it reflects sort of the wording from the 2008 version. And here on the photo you see when this DOH version of 2013 was adopted in Fortaleza in 2013. Now, let me finish with a few more words regarding accessibility and usability. The DoH was written and is written by physicians. So it's firstly and foremost a moral obligation for physicians. Although the WMA has always invited other healthcare professionals, other researchers to adopt these principles. The DoH has served as a basis for the development of other international guidelines, so other regulations do exist, but they have a different historical context and also a different mission. Still, the DoH does exert considerable authority upon national and international legislation, and in some cases, it has also been codified into law. A key feature of the Declaration of Helsinki is that it's not a detailed rule book, which some other guidelines are, and they have their specific purpose. No, it's not a detailed rule book, but it rather provides a concise set of easy-to-read ethical principles. Because the usability aspect and character of the DoH has always been very important and has always been retained and enhanced during the several revision processes. And the DoH underwent a couple of revisions because it has always been considered a living document to account for the new ethical challenges presented by changes in the methods and scope of medical research. And I have listed here all the years with rather major revisions in 1975, in 2000s. I mentioned the clarifications in 2002 and 2004. And then the 2013 version, the Fortaleza version, was also a rather major version where it was also completely restructured. It got a new structure of the paragraphs, and currently it's also being revised. And I'm looking forward to Dr. Resneck's presentation. During all these processes, we had a number of international meetings, expert meetings, and public consultations, and I'm pretty sure that many of you also participated in the public consultations in the past and in the current one. Now, I would say the DoH has more uncontroversial than controversial aspects. However, of course, conflicts will inevitably exist. For some researchers, for some people, it is already too restrictive, while for others, it is far too liberal already. So I assume the conflicts will resist, but it is rather uncontroversial with most of the paragraphs than controversial. But the DoH remains at the forefront of providing ethical guidance from biomedical research. And with that, I would really like to thank again the organizers. And I would like to thank Dr. Kloiber, the Secretary General, and Dr. Jack Resneck, who is chairing the current work group and who is doing really an amazing job to guide us through the whole process. It's really not an easy task, and Jack is doing a wonderful job. So thank you very much for your attention.
Thank you. Thank you very much, Ramin, for this introduction. And indeed, the 2013 version, the Fortaleza version of the Declaration of Helsinki, for the time that I can overlook, and this is now more than half of the history of the Declaration of Helsinki, has been the most stable and uncontroversial version. You have seen there have been different steps in the development of the Declaration of Helsinki, as Ramin mentioned, with some of the core achievements that the Declaration of Helsinki has brought. In the beginning, the informed consent, the first time in an international document being asked for. 1975, the mandatory challenge to have a consent of an ethics committee. Later, the inclusion of the demand for publication and registrations. All those points the WMA has not invented. There were countries which had them before. There were clinics which had ethics committees before. But what we have done is we have made it an international standard. And those principles came on a new level with the Declaration of Helsinki. And I think this is the real value of the Declaration of Helsinki. Now, when I say the 2013 Fortaleza version is a very stable version and the least controversial, at least the least controversial that I know, and as I said, I can overlook quite a time of the use of the Declaration of Helsinki. So why are we going into a revision? Now, the world is developing and health research is developing. One part has already been mentioned, that we had to branch off from the Declaration of Helsinki, that is the use of data and biobanks for research, which need some special rules and requirements, which we have coded down in the Declaration of Taipei. But then how we do research, what are the methods for research, has changed as well. And the social sphere in which research is being done has changed as well. And those were finally the things which have made us taken the decision to go into another revision cycle. And as the World Medical Association is a membership organization, we are very much depending on the willingness of our members to take a large part of this work of development, of rewriting, of discussing, of hearings into their hands. And I'm most grateful that this now has been done by the American Medical Association and the then president, Dr. Jack Resneck, now past president of the World Medical Association. And Dr. Resneck is professor for dermatology in California. He is also our chair of the Finance and Planning Committee of the World Medical Association. And Dr. Resneck has taken it on his shoulders together with his team at the AMA to go into this process of revision. And you will see that this is really a big task with a lot of work, a lot of discussion, a lot of travel, and a lot of meetings around the world. Dr. Resneck, the stage is yours.
Thank you, Dr. Kloiber, for the kind introduction and for your leadership of WMA over the years. Dr. Parsa-Parsi, thanks for the great presentation and the wonderful context. And thank you all for the invitation to join you and for putting up with my virtual attendance from afar. My apologies that I can't be with you in person, but I am looking forward to, over the next few minutes, sharing a bit about our current revision process. Hopefully you can see my slides. And I'll try to be brief and give a high-level overview because I'm very much looking forward to Dr. Cardoso's presentation, and also I can stick around for some questions. And one of the great things about this process has been all of the feedback we've gotten during regional meetings and from public comment periods. And so we learn at every opportunity that we have, and meetings like this are a great opportunity as well for us to hear from bioethicists and from the public as well. So you heard a bit from Ramin about how the Declaration of Helsinki is a living document, and a sense for the revisions and additions over the years. And Otmar just raised sort of the important question about if this is a core ethical document, and many of our fundamental ethics as researchers and physicians and medical professionals should be constants and high-level standards, why do we need these revisions every decade or so? And as Otmar just said, we have discovered over the years a couple of things. First of which is there sometimes are harms that previous versions have not addressed that we see happening out in the world. So as you look back over the years, whether it's for decades, the lack of an ethics committee being required to have somebody other than the researchers responsible for reviewing research protocols, whether it's the abuse of placebos that we have seen in other decades, vulnerable populations being abused in various ways. So first of all, we have these harms that were not addressed that need to be addressed. And secondly, there are new risks that evolve in a new world. And so, for example, in the last decade, with the emergence of big data and artificial and augmented intelligence, we've certainly seen new risks to confidentiality from our patients and research participants. Environmental sustainability obviously has come into our conscience more and more in the last few years. So things do turn up that we decide that we do need to address in the document, and that's why I think it's only gotten better and better and better with these revisions, and why we are continuing in that tradition with the 2024 version that we're working on. This process has been already going on for more than 2 years. The World Medical Association Council, which really functions like the board of the World Medical Association, established the working group that Otmar mentioned back in April of 2022. And we have really worked to make this an inclusive process with opportunities to contribute around the world. Since we, or you all, are in Brasilia right now, I do want to highlight and thank our 2 Latin America-based members of our diverse working group, Carlos Serrano, representing the Brazilian Medical Association, and Alarico Rodriguez, representing Uruguay, have both been outstanding members of the work group who have brought a lot of fantastic input to the discussions. A second piece of this process, and really the core piece for us at the World Medical Association, has been this series of regional and topical meetings that have been held across the globe to gather feedback. And this is really where 2 things happen. A, where we hear about which sections of the declaration are primed for revision, and debates take place and fantastic discussions around those potential changes. We've had regional meetings already in Tel Aviv, and each of these really is focused on a topic. The Tel Aviv meeting was focused on the implications of big data and machine learning and artificial intelligence. That was followed by a meeting in Sao Paulo, Brazil, focused exclusively on ethical considerations of the use of placebo and that paragraph and its controversies, as you heard about from Ramin. We moved on next to Copenhagen, where we talked for a couple of days about emerging trial designs and whether new approaches to clinical trials and research, branch trial design, et cetera, required changes to the declaration. We met next in Tokyo, and the Tokyo meeting was focused on research during public health emergencies and pandemics. This felt particularly important in the wake of COVID. Our next meeting was at the Vatican, and you'll notice that these next 3 meetings in a row really were all dedicated to discussions of various aspects of vulnerable populations. So the Vatican meeting was focused on research in resource-poor settings and issues of global justice. Our next meeting in Johannesburg on community inclusiveness, post-trial access, and issues of vulnerability. And in Munich, we spoke about specific and particularly vulnerable groups. We do have 1 meeting left. It is in Washington, D.C., and next month, August 15th through 16th. Would welcome anyone who can make it. And that is really going to be our final consolidation meeting and our talk about plans moving forward as we prepare to meet actually in Helsinki for the 60th anniversary and consideration of adoption of the next set of revisions. And we've also had 2 wide open public comment periods. This is a bit different than in the past. In order to really maximize opportunities for public input, we did this in 2 phases. with proposed changes coming out from the work group in one phase that really occurred back in February, and a second phase that just occurred earlier this summer in June and July to get public comment. And we were thrilled with just the volume and the thoughtfulness of public comments that did emerge. So I'm not going to dig into the detailed wording, given that we're already a little bit behind, and I really do want to preserve time for discussion, but I just want to give you a sampling for some of you who may not have seen the public comment documents that went out of some of the themes from the workgroup proposals for revision that have been put forth now in 2024. And again, this really has been informed by feedback from the regional and topical meetings and from the public comment periods. So I'm going to take it by section of the declaration, and I'm going to start with the preamble, where some fundamental changes have been proposed. The first one is really to replace the word subjects, which in today's world is viewed as somewhat paternalistic, and change that word subjects to participants, really out of respect for the rights and the agency and the importance of those individuals who take part in medical research studies on human participants. And we did that throughout the document as those words appear numerous times. The second is just a written recognition that those participants can include both patients who have an illness as well as healthy volunteers. And as Ramin mentioned earlier, this is a document that is created largely and overseen by the World Medical Association, a group of national medical associations made up of physicians. And it is, and the previous versions have, of course, mentioned the importance of these rights. But we added language, or proposing to add language this time around, that because these principles are so fundamental to respect for and protection of all research participants, that we are taking a stand that these principles should be upheld by all individuals, all teams, all organizations involved in medical research, and that it's not just speaking to physicians. In the general principles section, a number of things have come up that have led to additional proposals. One is the importance of medical research taking place in the context of structural inequities, and therefore the need to consider how the benefits and risks and burdens are distributed. This is really an issue of global justice, and there's proposed language around that. We've also discussed meaningful engagement with potential and enrolled participants, and especially their communities, before, during, and following medical research. Talked about the purpose of medical research, including advancing individual and public health, not just coming up with treatments for disease, but making sure that we advance the health of nations and of the world. Talked about, and as I mentioned, this was a topic at the Tokyo meeting, how essential it is to uphold the Declaration's principles during public health emergencies, and that there's not really a waiver of the Declaration of Helsinki during public health emergencies, while things may need to be sped up, and while innovations in how research is conducted and reported are important during emergencies like the COVID pandemic, that the principles still are the bedrock of participant protections and are so critical to the future trust of the research enterprise. We've added language around the inclusions of ethics review in all countries where international research is conducted, so that if especially clinical trials are being conducted across international borders, that ethics committees, both in the originating country and in host countries, are critical, and have added proposed language around avoiding or minimizing environmental harm through the research enterprise and promoting environmental sustainability. In this section on vulnerability, we've actually proposed substantial changes. We heard a lot in the Johannesburg meeting about recognizing that individuals and groups and communities can experience vulnerability due to factors that can be fixed or contextual and dynamic, and that even participation in a trial or study itself can put somebody who's not previously in a position of vulnerability into one. And then a lot of talk in Munich about balancing the protection for those experiencing vulnerability without depriving them from the important benefits of participation in research. This has really been talked about around the theme of responsible inclusion. And there were so many examples shared about where exclusion from medical research has perpetuated and actually exacerbated vulnerability and disparities. We think about the lack of data, for example, on various drugs and interventions and their effectiveness on pregnant women, for example. But there's also great recognition that those experiencing vulnerability do need special protections, and that there are particularly vulnerable groups, for example, let's say the incarcerated, where retaining additional protections is critical and language is being kept regarding that issue. Around scientific requirements and ethics committees, we've added language on the importance of scientific rigor to avoid research waste, and the need for ethics committees themselves to have adequate independence and authority to resist undue influence, to make sure that they're adequately resourced. We see ethics committees in some areas asked to do enormous work and very critical work without the resources they need to do that work. Making sure that the membership of the ethics committee has adequate education and training and qualifications, and importantly, diversity among its members. We've had discussions recently about adding specific language potentially around patient or community members as well. And then a recognition that the current language doesn't explicitly state that ethics committees have the authority to withdraw approval and suspend ongoing research. A few other principles, and this is the last slide really on changes. Ramin talked about the Declaration of Taipei, but we felt it's very important to have language specifically in the Declaration of Helsinki, not only about biobanks and human materials, but informed consent for participants in research for the collection and the storage and the foreseeable secondary use of identifiable data, and actually calling out re-identifiable data, as we've seen in the last few years that de-identified data sets, thanks to today's technologies, can unfortunately be re-identified at times. We're maintaining strong language about limiting the use of placebo or use of no intervention or control groups that use anything less than the best proven interventions. Actually strengthened language about the importance of post-trial provisions. And finally, a bit of a rewrite of the paragraph on unproven interventions, which we saw misused in some ways during the COVID pandemic, as though the DOH were granting permission for interventions that had actually been proven not to be helpful, and instead really focusing on how the use in individual patients of unproven interventions, sometimes through compassionate use, should never be undertaken to circumvent the protections for research participants that are found in the Declaration. So I really look forward to Dr. Cardoso's presentation, and I will stick around for the discussion and look forward to questions and feedback from this group. As I mentioned, we do have this meeting coming up in August in Washington. Would welcome additional participation in that meeting. Thanks again so much for the invitation to be with you virtually, and I will turn things back to Otmer at this point.
Thank you very much, Jack, for your presentation and all the work you are doing. And please stay tuned with us because we would like to have you in the discussion after the next presentations. Now I have the pleasure to present you the man who made it the Fortaleza version, because he invited us to Fortaleza. And as I said before, Brazil has been a place where we had a lot of a discussion about the development of WMA policy, and especially the Declaration of Helsinki. But when he, Florentino Cardoso, was president of the Brazilian Medical Association, he said, wait a minute, it cannot be everything in Sao Paulo and everything in Rio, and you have to come to Fortaleza. And we had a General Assembly in Fortaleza, which then gave us also the Declaration of Helsinki. Dr. Cardoso is not only the past president of the Brazilian Medical Association, he is also member of the Council of the Conselho Federal. He is a surgeon from Fortaleza, and as I said, most important, the man who brought us there. It's your stage, Florentino.
Thank you, Otmer. It's a great pleasure to stay here. I am amongst friends, Otmer, Professor Rui Nunes, Ramin, and Miguel Jorge, friend and brother. I will speak in Portuguese, so sorry. It's better for me. But Ramin said many times the most important letter document to WMA is Declaration of Helsinki, many times. But the most pronounced word here is Fortaleza. Fortaleza. The best city in Brazil. The most beautiful too. Friendly people. And beautiful beaches. The water is warm. I'm here to represent CONFEMEL. It's a Latin American, Ibero-American confederation. Now in Portuguese.
Florentino, may I, I'm sorry, but most of us will not understand, or some of us will not understand.
I know.
There is no translation.
Okay.
And Jack.
No problem.
Okay.
Don't worry.
Thank you.
Go ahead. Next one, here. Principle and position of the CONFEMEL. The Declaration of Helsinki is a document of minimal ethical principles for medical research on humans, including research on human material. We must be considered as a whole, and a paragraph must not be applied without considering all other relevant paragraphs. CONFEMEL statement about recommendations or observations to Declaration of Helsinki revision. There is controversy regarding paragraph 33 on the use of placebo. The CONFEMEL changed your mind to better, I think so. But we must protect our patients. If you are testing something about one disease, for example, it's important that you must use placebo if you have any other kind of treatment. Never. Or if you are testing is some risks or more risks than another treatment. These reasons are not specified in the declaration itself, leaving the justification for them before the ethics committees of the countries. The statement itself recognizes risks, but also warning that great care must be taken not but to abuse it. The third one is current redactation on this paragraph 33 does not provide anything new with respect to the old paragraph 29 on the use of placebo in this circumstance. Its language is not clear for us. It raised new doubts and furthermore, it introduced great decision-making openness for local medical ethics committees in clinical research, which do not have the some legal and ethical guarantees in this field in all countries. One parenthesis, when we find to move the last revision of the Declaration of Helsinki 11 years ago to Brazil, is to promote more and more knowledge about Declaration in Helsinki in our country. More than 200 million of people. For in every clinical trial, the same methodological and scientific standard of using and safety, legal and ethical standard must be guaranteed for all countries and all patients. Declaration of Helsinki is to all the countries. Taking special care with especially vulnerable population or communities that need special protection. Some psychiatric patients, for example. The Declaration of Helsinki contemplated the special guarantee and protection required by any clinical trial. However, they are not sufficiently reflected in the word of the last sentence of paragraph 33. We request this review, modifying the current wording, including the reference to special protection that we mentioned in leaving the methodological, scientific, and pressing issues that are alleged in the declaration itself that not sufficiently explained. It should not to be investigated with a placebo in humans, whether that there is an alternative pharmacological treatment. I talked about a few minutes before. The last one, the value of the dignity of the human person is a supreme and unavoidable good when it comes to the ethical and legal approach to research and human rights are above all. The dignity of the human is a substantial and inherent value, so personal interest is supreme. Since the human is unique, individual, and unrepeatable, its primacy over any other interest is disruptive. The use of placebo or no treatment is a safe study or treatment where no proven methods effective. We discussed a lot of CONFEMEL about this, especially in March 2023 in Uruguay. The new Declaration of Helsinki review process was initiated by the WMA, considering the process is appropriate and timely. The time is change principles, customs. The working group abroad and diverse integrations, very good. The holding regional meetings an inclusive model to discuss the new revision. The topics identified in the work group for the review's focus coincide with the concern of the medical organization that are members of the CONFEMEL. This General Assembly of CONFEMEL declared it's necessary to address new topics on the Declaration of Helsinki, like artificial intelligence and big data. It's necessary to improve the paragraph related to environment care, inclusion of vulnerable population, informed consent, misuse of unproven therapy. We see a lot of unproven therapy during the last epidemic. Approve include monitoring of side effects. Reaffirm this position concerning the last two reviews and use the placebo and participants' access to post-trial benefits. Some special questions about our country, Brazil. Declaration of Helsinki is June 1964. The last revision, October 2013, Fortaleza. It's necessary to respect the laws of each country. It's about 15 years we are discussing a new law about research in Brazil. It's not easy to change it. It's not easy to evolution. But last May 28, 24, this law is approved. In Brazil, we have two cameras, federal camera and Senate, we approved the new law about research on federal camera, but it's necessary to approve too on the Senate. Patients interested after clinical trial conclude. For example, if I have a very successful trial and I use some patients, 100 in each arm, for example, how long I must to take free this medicament, this drug to the patients. In Brazil, there is one discussion about, for all the time, 2 years, 5 years. Guarantee of access to the best treatment. And think about negligence or hair disease, as I say here in Brazil, because the number is so short, hair disease, when you are testing any drug, for example. Then, I hope to learn more about the other speakers and with the audience. Thanks so much.
Thank you very much, Florentino, for your thoughts and bringing in again the Latin American perspective. And during the past revisions, especially the CONFEMEL group and our colleagues from Latin America have challenged this process quite a bit. And I would like to ask now one of our past presidents, one of the presidents of the 3 presidents of the World Medical Association, which have come from Brazil, Professor Miguel Jorge, to start with his reflections on the presentations which we have heard on the revision process as a start into the discussions, which we would like then also to lead with you together by asking us questions, by giving your comments. But first, Miguel, it's your word.
Thank you, Otmer. Thank you, Professor Rui. Thank you for inviting me to comment in this session. Before I will make my comments, I would just make an addition to what Florentino has said. Actually, the law 14874 was approved and sanctioned by the President of Brazil, and it will come to effect on the 28th of August. And this law changes a lot the CEP-CONEP system in Brazil, which is something that everybody is very much concerned about, because we don't know very well what will happen when the law came to effect. But I will make some comments about the revision, or the current revision of the Declaration of Helsinki. I think, first of all, I want to recognize the improvements that were made since the public comment period 2. I have the opportunity to take a look at the current version that will probably be discussed and approved in the Washington meeting that Jack Resneck has mentioned, and probably his final approval by the General Assembly of the World Medical Association next October in Helsinki. So I think I want to highlight these improvements. I think the inclusion in paragraph 6 of the concepts related to global justice and the engagement of participants and communities, since when the research is being developed, before being proposed, up to the end with the dissemination of results, I think it's a very good thing. Also, I want to highlight the inclusion in paragraph 7 of the concept of social value and the importance to public health, not just for the individuals who, for instance, has those kind of situations that are being studied by those research. I am glad to see that sustainability of research with human beings is enforced in paragraph 11. And as was mentioned before by Jack and by Ramin, the improvement of the involvement of vulnerable people in paragraphs 19 and 20. I think there are some other things, but at my consideration, those are the ones that I wanted to highlight. I have some questions for the discussion that could be by Jack or either way by Ramin. The Declaration of Helsinki is aiming to medical research involving human subjects, or now participants. I have the opportunity to be in both sides of the balcony. I was a part of the work group who revised the Declaration of Helsinki previously in the previous version, but I was also for 6 years a chair of the Research Ethics Committee of my university, seeing lots of research that are being proposed. In my university, at the beginning, we are just a medical school, Escola Paulista de Medicina, and the Research Ethics Committee was created under that field. So we are just analyzing research that was doing when we're conducting in the medical school. But now we are a university with 6 or 7 campi in different areas of knowledge, and we are seeing many research that involves humanities and social sciences. And there is a tendency in my committee to apply the same considerations that we use for biomedical research when those research are being. And this is a very difficult situation for us. So I would ask to you, what is medical research? Is research where at least one physician is involved, or there is another kind of concept of medical research that is the object of the Declaration of Helsinki? I think this needs to be clarified. I don't know if we have time for this revision, but I would place this situation for you. The principles that would apply to biomedical research are the same that we have to use for those other kinds of research in humanities and social sciences. When I was doing a literature review to prepare my presentation as of yesterday here in this meeting, when I was speaking on new technologies, the innovations, the impact of innovations in research, I take the opportunity to take a look at the new Artificial Intelligence Act from the European Union. And one of the basilar things that is structured that act is the different levels of risks. So it's different when we consider risks in biomedical research from the risks that we see for participants when they are participants in social sciences research, which is also related to health many times. So how this could be, in a way, being touched by the Declaration of Helsinki. Besides of that, is any group of data extracted from public sources like Facebook, Instagram, Twitter, now X, derived from a not personally identifiable group of individuals to be considered as human subjects? So what are the aims of research? Human subjects. We have lots of data now being researched, come from public, from the web. Are these to be considered things that are human subjects and that needs to follow the principles of the Declaration of Helsinki? And I think the last thing that I would like to place to be comment is how we can consider the requirement for informed consent during a public health emergency such as the pandemic, or when we are using a biobank, large data banks, or even, again, doing sociological research. On regards of the informed consent content, when informed consent produced during the, when information is produced during the research are not part of the content of the informed consent. Because sometimes when we use artificial intelligence, generative artificial intelligence, data are being produced during the process. And it's impossible to predict what will come to include in informed consent, how we can deal with this matter. So I think these are the things that I would like to place to be commented by our previous speakers. Thank you.
Thank you very much, Miguel. I think there was already a whole bunch of questions, if not challenges, you have raised, and together with the ones that have been raised by Florentino, especially the question of the use of vulnerable groups, the question of use of placebos, and also the respect or the notion of access to post-trial access to care, which is important for that. Maybe I give the word first to Jack to comment on the questions that have been raised by Dr. Cardoso on the question of placebo use. What has the work group so far thought about that?
Thanks, Otmer. Yeah, I mean, I think, we had this singular meeting exclusively focused on this issue, and as Ramin predicted, we do hear a whole spectrum of viewpoints as to whether the existing document is too conservative or too liberal on this front. I think the consensus that we heard coming out of this is that the balance that is largely struck in the document is a good balance. We're not proposing to weaken any of the items that are in there right now related to placebo. CONFEMEL has actually been very helpful along the way. We have made some small language changes that have been suggested by CONFEMEL. So I think we're in a good place on placebo, but we're certainly open to additional feedback. I really was struck by Miguel's comments around this notion of what is included in medical research. Miguel, you really struck right immediately to what I think is a fascinating and interesting question. And we've had a lot of discussions over the course of the last 2 years about that term medical research. There have been discussions about whether we should change to health research to broaden to the types of research that are coming to your ethics committee at your university. And it's something we have struggled with, I think, as our commenters have struggled with as well. On the one hand, there clearly are things that might not be included in traditional medical research that we might want the declaration to apply to. So if somebody is doing a study on food insecurity and whether having healthcare professionals and physicians be able to write prescriptions for a food pantry and randomize people to this and see whether it affects their future development of diabetes, that's probably something we'd want to wrap our arms around and think about those participants and their rights and the responsibilities of the researchers. And yet there are other things under the umbrella of health research and that larger umbrella that happen in the social sciences that probably have very little to do with medicine and the origins of this document. So we continue to kind of weigh the risks and benefits of changing that language. We have not put out a proposal to change from medical to health at this point, but we're still gathering input on that.
Thank you very much, Jack. Another question that Florentino raised was the question of the abuse of the term of research and science. What we have seen during the pandemic, when very spooky experiments were done, or when individuals tried to sell their self-invented remedies under the auspices of so-called science. Will there be a response in the Declaration of Helsinki to that in the new version?
That to me or Ramin? Ramin, do you want to take that one?
Yes, Jack. I think you're on the spot.
Okay, I'm on the spot. So, I mean, I think this falls in a couple of categories under the declaration. And it's interesting, this is not a new problem with this pandemic. I think about my own country, the USA, and our American Medical Association, which is about 176 years old, not as old as some of the medical associations around the world, but it was really founded out of snake oil remedies and trying to put a stop to that. And so this is something we've seen for hundreds of years. So there was this one piece that I mentioned where we actually are adding language to the declaration just about the notion that public health emergencies don't change the Declaration of Helsinki, and that every single protection listed in the declaration still applies during public health emergencies. It may be possible to speed up ethics committee review, to speed up the publication process and still maintain all the same protections. And some of that innovation may be very important during a big public health emergency. But the maintenance of those protections is very important. And then there is this last paragraph really on unproven therapies. And there was a word in the old version of that paragraph which basically said, and I don't have the, actually I do have the old language, in the treatment of an individual patient where proven interventions do not exist or other known interventions have been ineffective, the physician, after seeking expert advice with informed consent from the patient or a legally authorized representative, may use an unproven intervention. And I think the intent behind may use was to say, hey, this happens sometimes. We have compassionate use and other mechanisms. But the word may was called out by some of those folks peddling snake oil and interventions that we knew or had been proven not to work, as to say the DOH actually gives me permission to do that. And that was certainly not the intent. So we have proposed a rather substantial rewrite of paragraph 37 to get rid of that word and to rephrase it to say, yes, there are mechanisms that different countries use to allow unproven therapies to be used by individual physicians and other healthcare providers. When that happens, the following things are very important, and to restrict it to sort of the relationship to the research enterprise, which is, A, we don't want patients experimented on without all the protections of the DOH, and therefore those consultations are very important. B, we don't want the research enterprise and the benefit to the rest of public health and social benefit and the community to be lost when this happens. So the importance, for example, of actually sharing the data when appropriate from those individual interventions. So those, I think, are the two things probably most closely related to that issue.
Thank you very much, Doug. From Miguel, there were three questions which actually related to new technology, or actually the use of big data and AI. And if I may summarize them correctly, you said, first of all, what are the different levels of risks and how can they be taken into consideration in an ethical regulation there, which we have. You also mentioned about the use of public available data for medical research, because it may be flowing into medical research without people knowing that their data is being used, or how have they to be asked. And how should we then consider the requirements for informed consent in these new circumstances which we have? There's another question, and I think you, Florentino, also raised it as a challenge. Have we looked into the question of AI and those technologies when we were discussing the Declaration of Helsinki? And maybe I start with the last point on AI and new technology. After you have met in CONFEMEL, we had the session in Copenhagen. And in Copenhagen, we discussed the question of new technologies and new research strategies and new data use in classical research. And the question was, does this change, or does this bring up a need to change the principles in the Declaration of Helsinki? Jack, would you like to respond to that? Did you find a need to change the principles?
It's interesting, even at that Copenhagen meeting, we really were all looking at each other and basically agreeing that around new trial designs, while there are specific things like expertise within the ethics committee that are very important, that we couldn't find aspects of the declaration that probably needed to change, and that most things applied to new trial designs. On the other hand, I think the issues around AI and big data and the substantial new world that we're entering around risk of loss of privacy and confidentiality related to those, it was felt that the current language didn't adequately address that, because it really is a substantial new risk and biobanks just are not adequately, it's not broad enough to sort of deal with all the genetic issues and the big data issues. But I think, we heard from Miguel this issue of data source. And is it, if somebody's using a publicly available thing like Facebook, is that medical research that would be subject to the declaration? And there are certainly gray areas there that I think largely get left to research ethics committees to decide if something is exempt. One of the things that we really are addressing because of the nature of the Declaration of Helsinki being focused really on participant research and medical research using human beings. We're really focused on secondary use of research data as an important thing, so that when somebody enters a research trial and data are collected from that research trial, there are important things around the consent process for entering that trial related to how those data will be used in the future. Will they be sold to a large data technology company? Will they be utilized in additional research projects? And that to the extent possible, the consent process needs to include those discussions. And that there are times where there's unforeseeable secondary use, and sometimes where you actually need to go back to participants maybe for additional consent where the risk is high, or other times where we put in language essentially saying, if it's not possible or feasible to do that, which you can imagine those times will arise, and we certainly heard from countries about this, that you still need to go to a research ethics committee to get a thoughtful external review about whether unforeseen secondary use of data are important. I guess lastly, as to the Facebook issue, if you're really just gathering something that's publicly available, depending on the risks that you're adding to the participants and the level of identity that you're using, it probably wouldn't fall under the umbrella of medical research, and it's certainly not secondary use because those data were not gathered. The Declaration of Taipei might be more likely to come into play than the Declaration of Helsinki there.
Thank you very much, Jack. And I think that's an important hint. Some of the questions that you have raised, Miguel, are certainly already addressed in the Declaration of Taipei, which then is an extension of the Declaration of Helsinki into the field of data research on biobanks research. At this point, I would like to invite you, if you have questions to the panel, and please come forward to raise those questions. That's now the opportunity to ask or to make comments if you so wish. Yes, please, there is one.
My name is Vinicius Nina. I'm the president of the Brazilian Society of Cardiovascular Surgery and also a member of an American charity. It is CardioStat International that offers cardiac surgery to underserved population, especially in Africa. So my question to Jack is, in your opinion, there is any important change regarding in this new version regarding the vulnerable population? And the second question is, does this new version brings any observation or consideration regarding humanitarian work in underserved areas of the world?
Thank you for the question, and thank you for your service and your medical work. I'd love to hear more about it sometime. So yeah, the vulnerable populations is one of the more significant changes that are being proposed in this go-round and that have gone out for public comment in phase 2 based on these 3 regional meetings. And as such, paragraphs 19 and 20 have been substantially rewritten. One of the changes that I sort of hinted at in my formal comments earlier was this change in language from talking about vulnerable groups, where really, we as the researchers from on high might paternalistically identify what we see as vulnerable groups, to language that talks more about communities and individuals and groups who are experiencing vulnerability. And that acknowledges their role in identifying themselves at times when we don't see that vulnerability. And B, it really acknowledges that it's not just fixed factors that we think of like gender or LGBTQ status or incarceration, but that there are contextual and dynamic factors that can make people more or less vulnerable at different times for different reasons. And the other change here is really trying to strike this balance between, on the one hand, we know that we need special protections for vulnerable groups. We have looking at the history of where the Declaration came from out of World War II, and then all of the many abuses we have seen over history that have involved vulnerable groups, that this is an imperative that has to stay here. But we have also seen the results of sometimes maybe being too firm in our, again, sometimes from the research perspective, defining those vulnerable groups and what they should or should not experience. And that there are times when those communities actually can have their vulnerability perpetuated or exacerbated by just automatic exclusion from research. And we had many examples about, for example, the lack of data on drugs and their effects on women, their effects on pregnant women, their effects on younger patients, because those groups are so systematically excluded from research. So there's more discussion of kind of responsible inclusion, and then sort of separating, and we don't get into the details of defining this because the Declaration is a high-level document, and it would be 100 pages long if we decided to try to define what is particularly vulnerable. But the acknowledgement that there are particularly vulnerable groups where the rules around subsidiarity and the requirements to be included in research being very strict, but larger groups experiencing vulnerability for whom we need to really focus on responsible inclusion and what that looks like. So that's really what we've tried to do with paragraphs 19 and 20. Thank you for the question and the comment.
Thank you, Jack. As a longtime companion of the World Medical Association and a critical observer to us, would you also like to comment on the process?
Thank you very much. I would like to make a comment on this last intervention of Jacques Resneck. A recent report of the World Economic Forum stated that if women's health was equally good as men's health, it would immediately inject in the global economy more than $1 trillion. Of course, the problem is not the economy, is ethics, is justice, is global justice. But my comment or question is, why does this happen? Because it is not only a matter of less access to healthcare. It is essentially because data for human research is not from women, and the research and clinical trials, even in the animal, is in the male participant, and in human trials also. So there is not enough research on diseases specific of women, but even in regular diseases that affect both men and women for different reasons, the results are biased for men and not for women. And therefore, the results can be no other than the one that exists right now. And my question, although Jack has already mentioned it, is if this issue that affects more than half of the world's population, so it is a special vulnerable group because it's half of the population of the world, it has been addressed by these preparatory meetings of the WMA.
Thank you, Rui. I'm not sure who wants to answer, maybe Jack again, the question of inclusivity.
Well, all I will do is, I just want to second the important comments about why we are where we are. And I don't think there's a single explanation, but we know a lot of the driving factors, and how much each of these are at play probably varies geographically, but one only needs to look at who was driving the research enterprise for the last century to explain some of what we're seeing. It has tended to be men in research positions, and fortunately we have diversified our research enterprise, but obviously not enough. So that's a piece of it. There are aspects of paternalism and not doing research on women to protect them that have been problematic. In some cases, it's just pure misogyny. In some cases, it's political. There are so many different drivers of this, but I think the comment about women's economic access to economic power and access to healthcare and access to the research enterprise are tremendously important.
Thank you, Jack. If there's no other question, then maybe there's one more, and then I will make a final comment because I have been reminded that we have to close. The lady over there in the fifth row, please.
Thank you to all the panelists for a very timely and insightful presentation. I think 2 congratulations are firstly in order for the success of the revision process so far, as well as for, I didn't know that the Brazilian law has in fact been adopted, so many congratulations to the government. It's a much needed law. I'm Nishtha Arora, I'm a healthcare lawyer, so I think my question would pick on to the legal regulatory aspects of the presentation. And any of the panelists can answer it. It's not addressed to anyone in particular. I noticed one point in the presentation which called for the need to respect for laws of each country, which indeed is important because otherwise the best of ideas can just be aspirational if they can't really be implemented. So I think my question is that what is being done to ensure this respect part of laws in practice in the implementation, in the revision process rather, or is the onus on the medical practitioners in their respective countries once they are working through the revisions and adopting them in practice? If I'll just sort of summarize it, is something being done in the revision process about it, or does the onus lie on the medical practitioners? Thank you so much.
Good question. Otmar, can I take a piece of that and bounce one piece back to you?
Please, please.
And the piece I want to take is just a clarification, because this does get misunderstood sometimes when the language in the declaration about how the declaration interacts with national law. And because this is a core ethical document, we see it as setting a floor, but not a ceiling. So when we say that it supersedes national law, we mean that a country cannot, through its legal process, or really ethically should not through its legal process, undo any of the protections of the Declaration of Helsinki or weaken any of those protections. But to the extent that a country would like to add protections, that is certainly a worthy and ethically possible approach. Otmar, you might have a bit to say about the work over the arc of these years that the WMA has done and continues to do to try to continue to make sure that this document has influence and is picked up by countries and regions.
Thank you, Jack. Yes, the Declaration of Helsinki indeed has made it into many of the laws on, for instance, pharmaceutical testing, on clinical trials in some of the countries. It has been referenced in the European regulation on the clinical trials. So it has become kind of a binding instrument, at least a very important landmark. The World Medical Association itself has no power to enforce anything. We have only the power of the argument which we can give and the hope that it has been heard. But looking back at the time of 1964, at that time in most countries there were no laws on clinical trials. That was the beginning actually. And here I would like to come back on the question of inclusion and inclusivity of the research as a final remark in reflection of the development of the Declaration of Helsinki. 1964, already far away from the Nuremberg trial, the Declaration of Helsinki was adopted under the impression of the thalidomide crisis. You may remember that at that time, thalidomide was a medicine that actually was given very often to pregnant women, and it turned out that it produced very severe mutilations to the embryos and to the fetuses, and children were born without arms and legs at a large number. And I have been told in interviews and talks to people who have been part of the crafting of the first version of the Declaration of Helsinki that this was the most important impression they were under when this was done. And this was also the starting point that then nations started to have laws on clinical trials and to regulate them. I think it's too easy to say, well, this was benevolent paternalism. I think there was a lot of fear that with experimentation there would be repetitions of these events in that. And that has made, of course, big liability charges to industry and to others doing experiments with that. So it would be a little bit too easy just to blame it and saying, well, this was a male paternalism to that. I think there was a real danger that we had seen at that point, or they had seen at that point, and came forward. For my own observation in the past 30 years, I can tell you that when we did the revisions in 2000, when we did the revisions in 2008, there was a lot of pressure on the World Medical Association to exclude verbatim the research, for instance, on children. There was a lot of pressure to exclude the research in poor regions. We did not do that because we thought that, of course, there has to be research for children and for specific diseases occurring in children with that, and you can do them only in children. We, of course, said there has to be a research participation of poorer nations and poorer regions, and we have to include them and not to exclude them from that. And this has completely changed. What we have seen now as a challenge is, why are you not including women, as it has been asked here? Why are you not including pregnant women in research? Why are you not including poor, resource-poor communities in the research? And yes, this is now the challenge to bring this in and to make clear that participation as patients and as researchers for those groups is of crucial importance for the development of research, for the protection of these groups, for the service of these groups, and also for the development of the healthcare systems. And if there is no further questions, then I would like to close and ask Rui to give a final word and then leave us for lunch. Thank you.
Thank you very much, Otmar. It was an excellent panel. Thank you very much to Jack Resneck that is with us by Zoom, all the participants in this panel, and I wish all of you a good lunch. See you at 2 o'clock.
Thank you to our speakers for their insightful presentations. We will now have a lunch break. We will return to our activities at 2 p.m. with the parallel sessions. Please refer to your program for details on the sessions you are interested in attending. For those participating in the working lunch, please proceed to the rooftop. You may also take this opportunity to view the posters and to enjoy the art exhibition by Isabel Saraiva. The exhibition is located in the outdoor area, so feel free to step outside and immerse yourself in the beautiful artwork. Please ensure you return to the auditorium at 4 p.m. for the final sessions and at 6 p.m. for the closing ceremony. Thank you and enjoy your lunch.